Thank you, Shinyo. Good afternoon, ladies and gentlemen. Mr. Chairman, I'm very pleased to have been asked to give this presentation dealing with the impact of body mass index and the metabolic syndrome on outcomes in atrial fibrillation. My disclosures are on this slide. Please take note of these. First, let's take a look at the prevalence of obesity around the world using 2017 data from the OECD. It's no surprise, I think, to any of us that obesity is extremely common in the United States and some of the affluent Western countries. On the other hand, you'll see there's a considerable difference with some of the countries in the Asian Pacific region, for example, Japan, Korea, India, Indonesia, and China. In summary, I think we could say that more than 1 in 3 adults in the United States is obese, and more than 1 in 4 adults in Mexico, New Zealand, Hungary, Australia, UK, Canada, Chile, and South Africa are obese. What was the situation in the Garfield database? Well, this shows very similar heterogeneity. We can see that obesity was very prevalent in Egypt, the United States, Australia, United Arab Emirates, and Finland, for example, but it was very uncommon in India, China, Japan, and Korea. We can see, however, that the figures are roughly double in the Garfield registry of patients with atrial fibrillation in the Asian Pacific territories and about 10 to 20% higher in the atrial fibrillation patients in Western countries. In the Framingham database, the BMI increase raised the risk of atrial fibrillation by about 4%. And I think we all recognize that this is predominantly due to indirect mechanisms, such as the coexistence of type 2 diabetes and coronary disease, obstructive sleep apnea, and associated hypertension with cardiac sequelae. There's also, of course, a direct effect of inflammatory adipose tissue being deposited subepicardially in obese patients. The objectives of this analysis is to describe the clinical characteristics of patients with newly diagnosed atrial fibrillation in the Garfield population, stratified according to their body mass index, to assess the impact of body mass index on antithrombotic treatment patterns, and to describe the impact of increasing BMI on outcome events, all-cause mortality, cardiovascular and non-cardiovascular, stroke and systemic embolism, and major bleeding. These are 1-year data of follow-up in the Garfield registry. The patient population is the entire prospectively collected 52,000 patients, of whom some 40,600 had BMI data. Of these, you can see that only a small proportion were underweight with a BMI value less than 20, and only 11.4% were morbidly obese with a BMI above 35. The majority of patients were in these intermediate categories, but you'll see that the normal range only included 26% of patients. Looking at their demographics, we can see that the age of patients is about 10 years younger in the morbidly obese compared with those who have normal or under or slightly overweight parameters. We can see also that as weight advances, the hypercholesterolemic percentages increase, the number of current smokers increase, and very importantly, permanent atrial fibrillation becomes more common, and paroxysmal atrial fibrillation becomes substantially less common. Looking now at diabetes in the patients who have various weight categories, we can see that diabetes increases almost linearly with the category of obesity, increasing from about 9.7% in those who are underweight to 43% in those who have BMIs above 40. These other characteristics associated with risk of bleeding and stroke are not substantially different in these patients. What happened with regard to their anticoagulation status? You can see that as weight and BMI increase, that the proportion of patients who are anticoagulated, the top of the orange bar, also increases. This is probably related to the much higher incidence of permanent atrial fibrillation and lower incidence of paroxysmal atrial fibrillation. If we look at outcomes, in this case mortality, divided into cardiovascular versus non-cardiovascular, the most obvious and striking different category are those who are underweight, in which both cardiovascular and non-cardiovascular mortality is increased. You can see that the reference values are according to the overweight category, but if we had chosen the normal category, it would not make a very substantial difference to this picture. We can see that mortality figures reduce as weight increases, BMI increases, except for the morbidly obese, where there is a slight increase in weight. If we look now at the causes of death in these various BMI categories, we can see that the only figure that stands out is the 43.9% of patients who are underweight who died from congestive heart failure. In all the other categories of cardiovascular death or non-cardiovascular death, there is no substantial difference as weight increases, as BMI increases. If we look now at patients who have no diabetes and look at the outcomes of all-cause mortality, stroke and systemic embolism and major bleeding, we see again that all-cause mortality reduces as BMI increases, except, of course, in the patients who then have morbid obesity. We can see that bleeding occurs more commonly in the morbidly obese, but there is not a significant difference in stroke outcomes. If we now look at patients who are not only increasing degrees of BMI, but also increasing prevalence of diabetes, you'll remember from about 9% in this category to about 43% in this category, you'll see that there is no clear direction in which any of these outcome parameters is moving. So, Mr. Chairman, I'd like to conclude that the majority of patients with newly diagnosed atrial fibrillation are overweight or obese, that patients with morbid obesity and associated metabolic syndrome, in this case type 2 diabetes, are almost 10 years younger than patients with normal weight when diagnosed with atrial fibrillation, that a higher BMI is associated with a greater use of anticoagulants, probably because of the decreasing prevalence of paroxysmal and increasing prevalence of permanent atrial fibrillation, that underweight patients are at higher risk of death, one reason for which is clearly the increased likelihood of deaths due to heart failure, that as BMI increases, the mortality paradoxically decreases in Garfield AF, but these are unadjusted data, and when, for example, we adjust for age, some of this may resolve. And finally, in patients with type 2 diabetes mellitus, this paradox is not at all apparent. Thank you.
Thank you.